Thank you for joining us on how government intervention is hurting competition in hospital markets, increasing patient costs, and limiting choice. Please welcome our host, Darren Bass, Senior Research Fellow in Regulatory Policy Studies at the Heritage Foundation.
Good afternoon. My name is Darren Bass, as was said, and I am a Senior Research Fellow here at Heritage. And we're fortunate today to speak with Bob Moffett, who's a leading expert in healthcare policy and a Senior Fellow in Domestic Policy at the Heritage Foundation. There's been recent attention on consolidation issues, largely ignoring the role the government has played in any consolidation. The Biden administration, as evidenced by its executive order on competition, brings up consolidation and competition issues, using it as a pretext for more government intervention in the marketplace. Consolidation in and of itself isn't necessarily a bad thing when private actors are responding to market forces and meeting the needs of consumers, but it is generally a bad thing when the consolidation is a result of the government distorting the market, which often hurts consumers. And today we're going to discuss such an example, government intervention that has led to hospital consolidation. And let's get right to it. Bob, it's really nice to see you, and thanks for joining us.
Good to see you, Darren. It's great to see you.
So I think a good place to start would be, can you explain whether there's really been greater hospital consolidation going on in recent years?
Sure, Darren. There's no question about it. A hospital consolidation happens whenever a relatively small number of hospital corporations or hospital systems dominate any given market. And yes, hospital consolidation has accelerated in recent years. And this has largely taken place through mergers and acquisitions, hospitals buying up other hospitals or systems buying up other hospitals and medical providers. Just to give you some idea, between 2009 and 2014, mergers and acquisitions among hospitals actually doubled. With the enactment of the Affordable Care Act, we've seen an acceleration of this activity. Between 2013 and 2017, there were 456 such mergers. And in 2018 alone, there were about 90 mergers. So the result is today that, according to the Federal Trade Commission, about 90% of the nation's hospital markets are highly concentrated.
Wow, it's amazing. And so if we kind of go through, so is consolidation first of all, is it hindering competition, and is it hurting consumers?
Oh, yes, there's no question about it. There's no question about it. You have consolidation means basically you have less competition. When you have less competition, you have less choice. Choice and competition are basically different sides of the same coin. Without choice, without alternatives, there is no competition. Without competition, there's no choice. And what happens is reduced competition means that prices are higher and the quality of services suffers. The concern that we have here at Heritage is none of this is happening in some kind of a policy vacuum. As you mentioned earlier, there are organic consolidations that come about as a result of consumer demand, and that's not necessarily the problem. The problem is government policy, and government policy at the federal and state level has in fact undercut market competition. This is true in two areas. First, at the state level, state regulatory policies in many parts of the country have inhibited the entry of new suppliers of medical services or innovative firms or medical professionals or delivery systems into the system. Certificate of need laws, which we'll talk about later, are a prime example of this. And the other side of this is that federal payment policy have contributed to market consolidation. Medicare and Medicaid are basically responsible for about 34% of all hospital revenues on average throughout the United States. But Medicare is such a dominant player in the marketplace. The effect is that the Medicare policies and Medicaid policies, to some extent, are restricting more robust competition among healthcare providers and professionals. And this is happening on the ground in different parts of the country, all over the country.
So I'm glad you brought up the government role, and that's kind of where we're going next. So So Bob's running a great new paper called How Congress Can Help to Reverse Hospital Market Consolidation. And so, Bob, in that paper, you explain hospital consolidation has accelerated since the enactment of the Affordable Care Act, which basically is Obamacare. Can you explain how Obamacare has led to consolidation issues?
Yes. I should point out that most consolidation took place well before the enactment of Obamacare. In fact, the data shows that most consolidation took place before the year 2000. But while Obamacare didn't create hospital consolidation, there's no question, and the data shows this, as I just mentioned earlier, that under the Affordable Care Act, it has certainly accelerated. And I think the reason for that is that the law introduced certain powerful incentives that have encouraged mergers and acquisitions and consolidation. I'll mention three of them. The first is that Obamacare, as a matter of governance, has been basically a vast transfer of regulatory authority from the states to the federal government. So the law basically federalized and centralized a large body of American healthcare regulation, which in turn has helped to contribute to further hospital consolidation. Now, the quantum increase in federal regulation has imposed very heavy transactional costs on medical professionals, doctors, and particularly hospitals. And what I mean by transactional costs is the cost of basically complying with this new regulatory regime. That takes time, energy, and effort, and also it takes dollars. The second thing is that Obamacare also made very significant reductions in payment for Medicare Part A providers. And of course, the major Medicare Part A provider are hospitals. Actually, these reductions in payment are really significant. $800 billion roughly in the first 10 years. Well, if you put these two things together, large institutions are really much better able to absorb both the transactional cost of heavy regulation as well as absorbing the payment reductions that have been imposed by Obamacare. And thus it made sense for hospital executives and corporations to look and see where they could merge with other institutions to absorb other institutions and basically share the additional regulatory burdens and share the additional transactional costs of Obamacare regulations. There's one more thing that cannot be ignored here, and that is the Obamacare, the Affordable Care Act, blocked reimbursement by Medicare and Medicaid for new physician-owned hospitals, including specialty hospitals, hospitals that specialize in cancer care, cardiology, and orthopedic care. This was a direct bar to entry of innovative hospitals. These are focused factories of high quality care. And it directly blocked this new class of potential competitors to the nation's large hospital systems. That's a direct assault on competition within the hospital market.
Just briefly, what was the motivation behind that last?
Well, I think large hospital systems and the hospital lobbies, the big hospital lobbies in Washington for many, many years have been arguing that they did not feel that they were getting fair competition from the specialty hospitals, particularly those owned by physicians. So they were very much opposed to the entry of these new hospitals. And my own view is that as a political matter, this is nothing more than, old-fashioned rent seeking, where the lobbyists basically use the law to block competition from other new firms, and the law has been successful in doing that.
So let's pivot away from Obamacare real quick and get into an issue that I worked in state policy, and this is an issue that I kind of got involved in myself. And that is, can you explain how state certificate of need laws have exacerbated this consolidation problem?
Oh, yeah. Yeah, on the ground. In the United States today, in 35 states, plus the District of Columbia, the way it works under these laws is hospital officials or medical professionals, new medical providers, they must go to a state agency, a board or a commission, and prove to that agency that there is a need for a new hospital, a new medical facility, or a need to expand the hospital or modify their existing hospital or medical facilities. This often requires very detailed studies, analyses, and statistical projections. And the result is that medical professionals, medical providers, often have to hire lawyers and lobbyists and consultants to help them go through this process. Now, I'm former chairman of the Maryland Healthcare Commission, which is a rather powerful regulatory commission. And I was involved in overseeing a lot of this. And I can tell you, it is a very time-consuming process. It takes up a lot of effort, not only on the part of the private sector, but also a lot of staff time to go through this. And sometimes, as far as the medical professionals and providers, it's costing hundreds of thousands of dollars. It can take months, or as I say, or even years. So then, if and only if the state agency agrees that there is a need based on the presentation of the hospital executives or the medical professionals, only then do they get a certificate of need, which is a kind of government permission slip to go ahead and start construction or open a new wing or modify some medical facility. That's the way it works. We do have we have a lot of evidence on this, but I will just mention to you that based on data developed by the Kaiser Family Foundation, it appears that states that have such certificate of need laws generally generate higher healthcare costs than states that do not. And based on the Kaiser Family Foundation data about the states that have these laws, generate healthcare costs that are about 11% higher on average than states that do not. The literature, the professional literature, the kind of stuff that you and I read all the time when you're doing economic or policy research, indicates that these laws increase, they don't decrease costs, they do not improve quality, and they directly harm competition.
I mean, the certificate of need laws are, they're troubling. And just wondering, has the federal government weighed in on it? Have they done any reports?
No, I've got some good news. Yeah, that's right. Okay, there's some good news here, and I think it's vitally important for people to understand this, that under both Democratic and Republican presidential administrations, the Federal Trade Commission and the Antitrust Division of the Department of Justice consistently opposed certificate of need laws whenever they have been called upon to testify concerning the economic impact of these laws. The Federal Trade Commission has argued that these laws work primarily as barriers to the entry of new providers. And given what I had said earlier about the fact that you have to spend a lot of time developing a case, that's not surprising. But the effect is not only to bar entry or act as a barrier to entry for new providers, they limit consumer choice, obviously, and they stifle innovation. In other words, both the Antitrust Division of the Department of Justice and the Federal Trade Commission have labeled these laws as fundamentally anti-competitive. And the evidence and based on their interpretation of the evidence in the states, these laws neither control costs nor do they improve quality.
So we've talked about Obamacare, we've talked about state certificate of need laws, and one area that you talk about in your paper, and I'm just going to, you write this, although a variety of independent factors have contributed to the consolidation, Medicare payment policy has played a powerful role. Can you explain how it's played a powerful role?
Sure. It's if you think about it, it's not too hard. Medicare, which accounts for about $926 billion in healthcare spending in the United States past year, is the largest payer in the American healthcare system. Medicare payment, the distribution of that payment and the conditions of payment have a profound influence on the private sector. You'll find often that the private sector payment systems shadow Medicare payment. In the case of Medicare payment for hospitals, Darren, the payments are higher for medical procedures that are delivered in a hospital or medical services that are provided in a hospital setting, and they're lower or non-existent if they're delivered in a non-hospital setting. Well, this is a powerful incentive, just the Medicare payment system, to centralize service delivery through hospitals rather than other kinds of medical facilities or clinics or other types of institutions.
So, Bob, I think now that we've kind of fortunately heard all these problems, let's start to look to solutions. And I know you make some recommendations for Congress. Let's go back to the state certificate of need laws. You recommend in your paper for Congress to take some action regarding state con laws. What can Congress do exactly?
All right, let's be very clear about this. State certificate of need laws are primarily a matter for the states and state legislators. It's a state responsibility. Obviously, these laws are state laws. The federal government has no right to interfere with the state's determination of its own intrastate commerce. So that's not a question. But I think what the general public has got to understand is that these laws do have an overall impact on overall healthcare costs in a state, but the federal taxpayers they're not insulated from the effects of these state laws. And let me explain. If the state con laws or the certificate of need laws are driving up the cost of care in a state, and if the federal government under current law is automatically subsidizing that cost through higher federal subsidies to the state, such as, for example, the Affordable Care Act insurance subsidies that automatically track state healthcare cost increases, then these states are obviously imposing an additional burden on federal taxpayers. It's one thing to impose healthcare costs on the citizens of your own state as a state legislature, but if you're starting to affect the rest of us, then Congress, I think, has a legitimate area of inquiry. My simple suggestion, and I'm not saying it's an easy suggestion, don't misunderstand me. My suggestion is that federal actuaries should determine the extent to which a state's con laws or certificate of need laws have that impact on increasing costs that spills over to federal subsidies. And Congress should adjust subsidies to the states to recover that proportional amount on behalf of the federal taxpayers. I think that's only fair.
Obvious. A question. I think we talked about this before, not today, but weeks past. Are the number of state con laws basically the same, or they've been a reduction?
They've been pretty stable, as I say, 35 states and District of Columbia. But the good news on this is that a lot of states are starting to rethink con laws, and there have been, efforts to repeal or review these laws, or to reform them or amend them. I think what we've seen in basically very recent years is we've seen efforts by state legislatures to amend or modify or reform con laws, and that's a good thing. You got to realize a lot of this is very, very much based on the politics that are particular to the state. And as I say, I mean, it varies from state to state, but you got to understand that many of the hospital lobbies are very powerful. And most of them, at least in my experience as chairman of the Maryland Healthcare Commission, they have been historically opposed to any kind of reform of the certificate of need laws. I can testify to that under oath.
So, one of your second recommendations, Bob, is to Congress is something you say site neutrality in Medicare. Can you just explain what this would do and why it would actually help?
Oh, sure. Yes, as I said earlier, Medicare generally pays more for a service or a medical procedure if it is delivered in a hospital setting rather than, let's say, a clinic or an outside medical facility or a doctor's office. The effect of that is, of course, it raises the cost not only for taxpayers but also for seniors, who, but the problem is it undercuts the entry of new and innovative providers who would otherwise be able to compete directly with hospitals on a level playing field. So my recommendation simply is that we pay the same for a medical service or a medical procedure, regardless of where that procedure is delivered. And what that would mean is that Medicare, which is, again, such a powerful player in the system, would establish a level playing field between hospitals and other medical institutions. And it would stimulate a direct competition between hospitals and these other medical facilities. We know from some earlier econometric work that would result in very big savings for federal taxpayers. But the key thing here is that direct competition would have a spillover effect on private sector markets that are so heavily influenced by Medicare. And I think this has bipartisan potential, frankly. You may recall that President Trump proposed a regulatory reform that would champion neutral payment for Medicare. And that's a very, very good idea. Frankly, we have taken a position here, my colleagues and I, that Congress should codify what President Trump did in regulation and expand it, frankly. It's also, though, this idea of site neutrality in Medicare payment, paying the same in a hospital as in let's say, a clinic or another medical facility, has been endorsed by the liberal analyst at the Brookings Institution, as well as the Center for American Progress. So frankly, there's absolutely no reason I can imagine why Democrats in Congress should not be able to get on board on this proposal.
Bob, do you know if the Trump rules, are they still in effect, or is Biden administration trying to get rid of them, or are they not
to the
doing
best
anything?
of my knowledge, they're still in effect. Yes.
So one of your final recommendations in the paper deals with the Affordable Care Act and repealing some of the provisions. What are the provisions that you were referring to, and how could that be important?
Yeah, there are a lot of provisions in the Affordable Care Act that I would get rid of before breakfast, to be honest with you, because I think they are counterproductive. They raise costs, and they have basically undermined consumer choice and competition in the markets, especially the insurance markets. But that aside, in this area, with regard to the market consolidation of hospitals, I think the most important change in this area would be the repeal of Section 6001 of the Affordable Care Act. I mentioned it earlier, but this provision prohibits physician-owned hospitals, including specialty hospitals, from participating in Medicare and Medicaid, just like all other hospitals. As I said earlier, this law blocks the entry of these hospitals into the Medicare and Medicaid markets. Darren, this is blatantly anti-competitive. I mean, you can't get any more anti-competitive than this. Now, there's mounting evidence and in the professional literature that these specialty hospitals and physician-owned hospitals provide medical care that is generally of higher quality than other hospitals, and they can do so at a lower or comparable price than other hospitals. So the law basically today is blocking entry of new and innovative hospitals that could deliver high quality specialized care. And that really means that the law is restricting senior citizens from having access to the highest quality of specialized care. And just as a matter of morality, this is, in my view, unconscionable. We have got to solve this problem. There's no reason to have that kind of special interest blockading of access to quality care because of special interest politics.
I'm glad you brought that up because, one of the things that, so I do some work on competition issues, and there's so much overlap between the competition issues and cronyism, and just flat out, doing favors for, sometimes people get surprised that a business or certain industries actually want regulation, but they want regulation because it creates barriers to entry, and they're able to comply with the regulations knowing that new entrants won't be able to, so I'm sure that's happening. It sounds like it's prevalent in the hospital market.
Oh, it's very strong. I mean, as I say, and generally speaking, for example, when it comes to things like certificate of need laws, in my experience, hospitals say, well, we don't really need any change in that. The existing medical providers say, oh, no, you guys are going too far. What are you talking about? Free markets don't work in healthcare. Get rid of that idea. And basically what they're saying in effect is that if you were to enact, let's say, a reform of certificate of need laws, you would undermine their position and you would undermine their profit margins by forcing them into competition with new and innovative providers. I mean, it's outrageous on many levels, but in the healthcare sector of the economy, it's quite common. And it is very, very, very intense in many, many, many different states, where you have both in the insurance market and also in the healthcare delivery market, where you have very, very powerful oligopolies in many cases that are perfectly happy to be with the status quo and take advantage of the status quo and have higher profit margins as a result of it. The problem is, of course, consumers suffer, prices go up, and quality suffers.
Hopefully it's not a curveball for you, but because I'm worried about consumers, I'm worried about patients, and I'm also thinking about kind of lower income households that, and a lot of, when you deal with like basic needs like energy and food prices that are going up, they tend to be disproportionately hurt. Oh, yeah. I would assume the same thing is happening when we're dealing with healthcare.
Not quite. And I'll tell you why. Because if you're lower income and you're in the private market, you're in the Obamacare insurance exchanges, and the subsidies for the Obamacare insurance exchanges, the lower your income, the bigger the federal subsidy. The problem is, and this is the difficulty, the problem is that every increase in healthcare cost, as a result, is a bigger increase on the taxpayers, because basically the taxpayers are picking up the tab. But it is true, for example, that if you're lower income and you're in Medicaid, you don't normally get access to the high quality care that people get in terms of specialty care or physician care that people get in private health insurance. The literature on that is pretty rich.
So, Bob, I know that you've worked on consumer-driven market competition in healthcare. Just kind of a big picture question. Why is consumer-driven market competition in healthcare? Why would it be good for competition and for senior citizens, for all Americans?
Well, you're asking a big screen question, and it's a very big issue. Let's look at the facts on the ground. The American healthcare sector of the economy is simply huge. It's about $3.7 trillion, close to, not far away from 20% of the entire American economy. It's enormous. The thing that characterizes the healthcare sector of the economy, however, is this. Most ordinary individuals have very, very little direct economic power when it comes to the big questions. For example, what kind of health plan you have, what kind of medical procedures and treatments and services you get in your healthcare plan, what you will pay in premiums or deductibles, what kind of access you will have to a particular set of specialized physicians, and so on. These decisions are made by other parties, employers, managed care executives, And under Obamacare, more and more, under Obamacare, the Affordable Care Act, these are government decisions. If you're in Medicare or Medicaid, these are all government decisions. What you get, what you don't get is all a matter of decisions, or decisions basically made by somebody else. The most important issue, in my view, in healthcare is simple. It is who really makes the key decisions in the system. Who controls the flow of dollars in the system? If the consumer makes the key decisions and controls the dollars, then insurance company executives, medical professionals, hospitals, clinics, all will be compelled to respond to the consumer's wishes. If the consumer has choice, real choice, then there will be competition. And where there is competition, there is, as you know, Adam Smith told us this back in 1776, there is innovation, there is cost control, and you will have increased productivity. This is true in healthcare as it is in every other sector of the economy. Where you have choice and competition, individuals and families will be able to get better value for their healthcare dollars. At the end of the day, that is best for individuals and families. And frankly, Darren, it's best for America as a whole. We do not have a competitive healthcare system where individuals and families make the key decisions and control the dollars. And until we get there, we are going to have a lot of dysfunction, a lot of waste, a lot of wasted energy among doctors and hospitals, clinics, and home health agencies, and various other folks who could do actually a better job. We do a pretty good job in many ways, but we could perform much better, actually.
Bob, I really appreciate it. I've learned so much just talking the last 30 minutes, and also reading your paper. I learned so much. So thank you so much for joining us today. And I want to thank everybody who's participating today in today's program and watching a recording of the event. I encourage you to visit heritage.org to learn more about the issue we've just discussed today. And please do read Bob's new paper, our other policy work. And of course, please look out for our future events, because we have a lot of great events coming up. I also encourage you to contact me directly using the information on your screen if you'd like to continue the conversation. You'll receive a survey immediately following this event. Please complete this so that we can bring ideas that you care about to the public square. Again, thank you. Have a great day, and we look forward to seeing you again soon.